Okay. So I'm going to introduce Dr. Noelle Adair. We are all very familiar with Dr. Adair. She has been spending a lot of time delving. You can't? Oh, well, hang on. Where is the mic? Where is he? Hold on just a minute. I don't think it'll record well if it doesn't have the mic on, right? You can hear me on, okay. Oh, now I hear it. Okay. All right. So Noelle is going to present to us some research that she's been doing on updates in vasoactive therapies for hepatorenal syndrome. I think she's done a really great job at trying to blend some of the basic overviews of this topic with some of the complex literature that is really changing the way we use some of these agents in the United States. So I will let Dr. Adair take it away.
Thank you for the introduction. Wait, why is this not? How can I forward it? There's no mouse on the screen. Click the enter or the over. There we go. Okay. Sorry, I have nothing to disclose. Thank you.
Yeah, we're not hearing we can't hear the microphone. It was better. Like,
should I just like lean into it like this the whole time?
It's getting lower than usual. Like our speakers. Might just need everybody use the here. People in the back here to move up so she doesn't have to.
Let's see if this one works.
Do you want me, I can just try to talk really loudly too, or this. This one, it is not doing anything.
It's voice activated.
Oh, okay. Is this better?
It's like the speaker is not working.
Yeah, I get it in the control room.
Okay.
It's coming through loud and
We'll
clear.
all move up if it's recording well.
It is, yeah.
Okay. Well, thank you.
Okay.
Okay, I will do my best to speak very loudly for everyone.
This may work also. Yeah.
Okay, awesome. Thank you. Okay, and so we begin again. I have nothing to disclose in this presentation. Here's just a list of abbreviations. I do want to point out the acronyms that are mentioned frequently, which are bolded here, including ACLF and HRS. At the end of this presentation, the objective is for the participant to be able to describe the pathophysiology and diagnosis of HRS, recommend first-line and alternative treatment options for the reversal of HRS-AKI, select an appropriate candidate for terlipressin versus norepinephrine use in HRS-AKI treatment, and establish an appropriate monitoring strategy for patients receiving terlipressin. So why does HRS matter? Cirrhosis is a disease state associated with high morbidity and mortality rates. Of patients with cirrhosis, there's an extremely high rate of patients who experience HRS-AKI, in which inpatient costs alone exceeded $18.8 billion in 2016. Just to digest these numbers a little bit, again, the median survival of decompensated and further decompensated stages is over 2 years and then around 9 months, respectively. Now, I want to move on to talking about the definition and diagnosis of hepatorenal syndrome. In 2015, the International Ascites Committee guidelines proposed these two following definitions. This was considered an old definition originating from 1996. Historically, in the setting of cirrhosis, HRS was classified as being one of two types, characterized by whether kidney function was affected in an acute versus a chronic manner. Type 1 HRS was defined as doubling initial serum creatinine to greater than or equal to 2.5, or a 50% reduction of initial baseline serum creatinine to reduction of less than 20 milliliters per minute in less than 2 weeks. Type 2 is listed here. However, in this presentation, we are going to focus primarily on type 1 HRS. Before we can understand how HRS is diagnosed, let's review the KDIGO definition we are already mostly familiar with. I would be remiss to not include AKI definitions, as this plays a huge role in the impact of guideline recommendations and treatment management in the various trials we will examine. Again, in KDIGO AKI definition, we have stages 1, 2, and 3. Historically, only stages 2 and 3 were specifically mentioned or important in HRS AKI. In 2021, a revised definition of HRS AKI was proposed, demonstrating that it is a functional form of prerenal AKI. This was important because it highlights predisposing nature of cirrhosis to renal dysfunction. Of note, this is typically difficult to diagnose, as it is commonly a diagnosis of exclusion. It is important to consider this updated definition when evaluating HRS treatment trials, because trials base their inclusion and exclusion criteria on the working definitions at the time the trial was published. Thus, it may not apply to specific patient populations. This brings us to our first patient case. A 64-year-old male with a history of cirrhosis with ascites presents to the emergency department with a serum creatinine of 2.4. After reviewing his baseline labs or previous labs, you observe that his baseline serum creatinine is 1.1. According to the updated definition and diagnostic criteria of HRS AKI, is this patient currently experiencing HRS AKI? So in this scenario, the answer would be C. We need more information. Did this patient receive the albumin challenge? Have diuretics been previously administered? We'll discuss albumin's role in diagnosis and treatment a little bit later. This is by no means a lecture thoroughly reviewing hepatorenal syndrome. However, I would like to provide you with a brief overview to provide a foundation which enables us to have a discussion so that we can appropriately review pharmacotherapy options. Cirrhosis ultimately results in an increased pressure in the blood vessels, leading to the liver, resulting in what we know as portal hypertension. The body then attempts to counteract these pressures via splanchnic vasodilation, leading to reduced blood flow and perfusion of the kidneys, resulting in the AKI we are familiar with seeing. Keep this in mind, again, as we review the various vasoactive therapies, which are the mainstay of revising this problem. Agents we will talk about include albumin, mitogen and octreotide, norepinephrine, and terlipressin. I want to remind you of the overall treatment goal of HRS AKI treatment, which is reversal, with the ultimate goal to improve survival and decrease need for renal replacement therapy, ultimately as a bridge for liver transplant. It's beyond the scope of this presentation to talk about the appropriateness of albumin in the treatment. However, I do want to note its critical role as a both diagnostic and therapeutic tool to promote volume expansion. First, we typically use an albumin challenge to help facilitate diagnosis. Albumin alone is not treatment, and that has been demonstrated in various trials. Potential risk of therapy. Okay, so as I review this specifically for staffing pharmacists, whenever we do see an albumin order in the queue, it's important to note whether it is albumin being used for diagnosis in the albumin challenge or for treatment, in which it would be given alongside another agent. In albumin challenge, we would typically give a volume expansion of 1 gram per kg of body weight with a 100 gram max for 2 days. and withdrawal of diuretic. Treatment dosing, recently approved by the FDA, is listed here. Common side effects that you may observe with albumin include pulmonary edema, fluid overload, or an infusion reaction. Of note, for an 80 kilogram patient, the cost for 14 days of therapy would be around $1,800. Now I want to move on to the vasoactive therapies we use for HRS treatment. These include midodrine and octreotide, norepinephrine, and terlipressin. This table demonstrates the various effects of midodrine and octreotide, norepinephrine, and terlipressin. This is not a chart demonstrating comparison of efficacy, but rather an overview of how these agents are specifically targeting each part of the pathophysiologic pathway we previously discussed. As you can see, terlipressin significantly impacts all of these modalities. First, I want to review midodrine and octreotide. Because it is a systemic vasoconstrictor, midodrine, speaking of, and octreotide can help promote splanchnic vasoconstriction. Theoretically, these two therapies combined should improve both renal and systemic hemodynamics. Midodrine, again, is more systemically selective, and octreotide specifically helps with vasoconstriction of the splanchnic portal. Dosing is listed for your review, in addition to common side effects that should be monitored when giving these agents to our patients. Of note, it is inexpensive. This therapy does not require invasive monitoring, doesn't require a central line, thus can be given to patients on the floor. However, studies demonstrating benefit and studies examining this benefit are limited. However, it is notably a cheap or more inexpensive treatment option for these patients. The next vasoactive we'll look at is norepinephrine. This is a recommendation in the 2021 guidelines. As a systemic vasoconstrictor, it also can help with the overall vasodilation and decreased perfusion that we're seeing in these patients. Dosing is listed there. Note, it is different than sepsis dosing, where it is typically administered in a fixed dose with a goal of increasing MAP and or urine output. Advantages include that it's inexpensive, easily acceptable to most institutions, and has a relatively low cost. However, it of course requires ICU level care and requirement of a central line at most institutions. Terlipressin is the next vasoactive we will review, which in 2020 FDA approved. This is unique in that it provides selective vasoconstriction of splanchnic circulation. Placebo-controlled randomized clinical trials led to the FDA approval for this medication. Ultimately, they found that terlipressin found an improvement in renal function and a decrease in the need for therapy. However, a boxed warning listed on the package insert includes hypoxemia and ischemia. In addition, respiratory failure was seen in the terlipressin groups at 15.5%, which is significantly higher than the placebo group it was compared to. And of course, dyspnea is also noted. Advantages can include that it can be given via IV peripheral administration and may not require ICU level care. However, it is extremely costly. Now I want to take a pause and review the evolution of HRS treatment. Walking you down this timeline will hopefully help provide a more comprehensive overview of what medications we use for the treatment of HRS AKI and what studies were coming out at the time to support these recommendations. The first one we'll look at is the 2019 guidelines. In this instance, HRS defined AKI as per Aiken criteria, and it included that terlipressin response was dependent on AKI, MELD score, and ACLF liver grades. In this, it did recommend continuous IV administration of terlipressin to be superior over noradrenaline or norepinephrine, and did not provide a recommendation for mitogen and octreotide. At this time, terlipressin had previously only been recommended for reduction of paracentesis-induced circulatory dysfunction due to evidence that when used with albumin, the therapy had a very synergistic effect. KDIGO criteria had not yet been used to assess this population. Of note, the definition of ACLF did not include kidney dysfunction due to reported renal dysfunction in up to 34 patients and as high as in 51 patients using Aiken criteria. This could have led to a significant miss or underdiagnosis of HRS, and thus treatment was not initiated, and those patients were not studied at this time. The first study I want to review is looking at the AKI, evaluation of AKI and its response to terlipressin. This was a retrospective clinical record of all consecutive cases of ACLF. And this was one of the primary pieces of literature that the 2019 guidelines used to support its recommendation for terlipressin. At this time, terlipressin was given as a bolus, and the primary outcome of the study was to look at survival at days 7, 30, and 90. It also defined response to terlipressin as a reduction in serum creatinine to less than or equal to 1.5. And they did look at treatment-related adverse drug events. This is a table of baseline characteristics of patients in this study, and it highlights the incidence of AKI and serum creatinine at baseline, MELD score, INR, and total bilirubin being important players in whether a patient would survive or not survive, regardless of whether they received terlipressin. These patients did all receive terlipressin, and as you can see, it was clinically and statistically significant differences. To orient you to this survival curve, which was also provided via this study, it looks at the solid line, which is the response to terlipressin, and the dotted line, of which patients did not have any response. Walking away from this study, I want you to remember that terlipressin non-responders did not have a different outcome at 90 days, but there was a slight difference at day 4. Again, while they stated they were looking for survival, this was really only examining survival at 90 days after receipt of terlipressin. Additionally, significant ADEs were not listed or experienced, including respiratory failure and dyspnea. Terlipressin, this is another study also examining terlipressin. However, it's examining it in comparison to norepinephrine. This is one of the first trials comparing norepinephrine to terlipressin as a randomized trial, which makes this a significant study. In this study, terlipressin was given continuous infusion, and noradrenaline was also given as a continuous infusion. The primary outcome of this study was reversal of HRS-AKI at day 14, which differed in prior studies, where we were only looking at serum creatinine reduction. The primary outcome demonstrated that terlipressin versus norepinephrine had a 40% versus 16.7% difference of reversal of AKI. It also notes that, again, complete response of terlipressin was seen at day 4, and then tracked until day 7, of which there were significant differences. However, when looking at overall mortality, it does state a statistically significant value. Of note, this study included patients with sepsis, and remember that these patients were receiving either terlipressin or norepinephrine. In conclusion, terlipressin did significantly improve reversal, and it also reduced the need for renal replacement therapy and overall mortality. But most studies previously done did not include patients who had sepsis. So you can assume that terlipressin and noradrenaline had various outcomes or effects on these patients. Next, we're moving on to the 2021 guidelines, which included the updated definition of HRS-AKI and did include terlipressin. However, it had not yet been approved for the US at this time. The recommendation stated that vasoactives, including either terlipressin or norepinephrine plus albumin, were effective in improving kidney function. This was one of the most pivotal updates, as the recommendations provided included multiple impactful practice-changing trials. The first study we're going to look at looks at whether norepinephrine can be used as a treatment modality for these patients. The overarching rationale is to look at what details brought us to the conclusion of using norepinephrine as an option. As you can see, HRS reversal occurred, however, it was in a very small sample size of 10 patients. This table one just demonstrates, again, the importance that AKI and baseline serum creatinine and urine output have on whether treatment is effective or not for reversal of HRS-AKI. In conclusion, reversal was statistically significant, but again, the small sample size limits our ability to apply these results to other settings. The next two trials are pivotal randomized clinical controlled trials in the management of HRS-AKI. To the left, we have the first randomized prospective double-blind placebo-controlled trial done in North America. Up until this point, they had all been European or international studies. The first study demonstrated that patients who received the albumin challenge first and then were appropriately given treatment were both in randomized groups, including terlipressin, and this was versus placebo. The other trial, reverse trial, is another one that maybe more people are familiar with. This trial was also done in the US to demonstrate whether terlipressin could have a beneficial effect in the renal function. However, they specifically were looking at, it's not in the study, the percent of patients with confirmed HRS reversal. As you compare these two studies, they again play an important role in the timeline of HRS management. The first study demonstrated that there is no difference in HRS reversal defined by percentage of terlipressin versus placebo, and there were no differences in survival. However, they did see a benefit at around 3 to 4 days. Additionally, transplant-free survival was first evaluated in this study. Moving on to the reverse trial, there was a meaningful difference again seen in serum creatinine and its impact on HRS-AKI reversal. However, neither statistically nor clinically significant differences in serum creatinine were observed, and there were no differences in survival rates at 90 days. This next study just demonstrates the difference that midodrine and octreotide could have in comparison to terlipressin. This again was looking at type 1 or type 2 HRS and excluded patients with septic shock. Diuretic agents were appropriately withheld, albumin challenge was given, and terlipressin was administered in a continuous infusion versus midodrine and octreotide given. The primary outcome of the study was complete response at completion of treatment. I have listed for you the doses that patients received and whether they were complete or partial responder. Again, we saw a significant improvement in HRS type 1 reversal. However, there was very significantly small sample size in this study. There was no difference in serum creatinine reduction or in side effects, but there was a significantly higher MAP observed in the terlipressin group. Overall, midodrine and octreotide did improve reversal, but there were no differences in survival, which is why it has a low recommendation currently. Moving on to 2022, in hospitalized patients with cirrhosis and HRS-AKI without high-grade ACLF or major cardiopulmonary or vascular disease, terlipressin or norepinephrine were both recommended. Terlipressin with finally a higher quality recommendation. In a systematic review or meta-analysis examining patients who had type 1 HRS, norepinephrine versus midodrine and octreotide versus terlipressin was observed. Ultimately, there was a moderate quality evidence listed for terlipressin, but low quality evidence for all other therapies. This was beneficial because it did include a large sample size of patients. Finally, this brings us to CONFIRM. This was a trial that was had been done in 2021, and thus was included in this 2022 guideline update. This was a trial specifically requested by the FDA to determine a primary outcome of reversal of HRS-AKI, whereas the previous two randomized placebo-controlled trials had only examined the percentage of patients who had serum creatinine reduction. It also included a rather large sample size of 300 patients. Patients, again, were appropriately given albumin for the albumin challenge and then randomized in a 2-to-1 ratio, receiving either terlipressin or placebo. And the primary outcome, again, was reversal of HRS, which also added survival without renal replacement therapy for at least 10 days after completion of terlipressin. First, we're going to look at the primary endpoint, which is HRS reversal in these patients. As you can see, there was difference between terlipressin and placebo. Overall side effects were first noted to be inclusive of dyspnea and respiratory failure in this trial, when these rates were significantly higher in this trial compared to other trials examining terlipressin. The take-home message for this trial was that HRS reversal in the setting of SIRS was significant in the terlipressin group and demonstrated higher rates of serious side effects than observed in previous studies. Next, we're going to look at the AGA guidelines, which included about the same literature as the ACG guidelines had included. This is the first time that FDA contraindications were included in the guideline recommendation as precautionary warnings. Additionally, it stated that bolus or continuous IV administration could be used. This was one of the trials that was listed in the guideline update supporting transplant-free survival of terlipressin in 90 days and looked at whether patients were given bolus versus continuous infusion. As you can see, the bottom line is a table of time and the y-axis is the survival rate. The solid line demonstrates patients receiving terlipressin boluses and the dotted of terlipressin given continuous infusion. This would lead one to think that giving a patient terlipressin via bolus administration may have better survival outcomes at 90 days in transplant patients. And lastly, this brings you to 2024 guideline update. This recommendation was just distributed, stating that terlipressin is a vasoactive drug of choice and does not require ICU monitoring and can be administered via a peripheral line. The purpose of this guideline was to provide timely guidance on a topic that had not previously been mentioned in their guidelines. This included a meta-analysis which demonstrated the differences in baseline serum creatinine in patient survivability. Obviously, patients with a serum creatinine of less than 3 had higher rates of survival at 14, 30, 60, and even closer to 90 days. This kind of makes you think that if you were implementing this in practice, would you want to restrict patients receiving terlipressin to a serum creatinine of less than 3 in order to receive this treatment? Again, just something to think about. Finally, we're going to look at terlipressin dosing strategies and the potential applications it may have to us. However, why are we wanting to talk about the different strategies? Should the following information give us pause before we adopt terlipressin into our own population? Noted here, added to this timeline of guidelines, is the European Association for the Study of the Liver. Terlipressin has been approved in Europe for around 25 years. However, we have never implemented it into our US guidelines. They first recommended terlipressin as a first-line option in 2010 and stated then in 2018 that norepinephrine could be an alternative option. In 2022, of note, when it was FDA approved for our use, eight people voted yes and 7 people voted no for the use of terlipressin in our patient populations. So why was the US so behind the ball? Let's look at a patient case first. We have a 37-year-old female, history of cirrhosis with ascites, presenting to the ED with a serum creatinine of 1.3. You review her previous labs and observe her baseline serum creatinine is 0.8. When doing her med rec, you speak with her partner who states she has an upcoming liver transplant in 5 months. What would be the best therapy for HRS reversal? I know I have it already highlighted here. However, I want to remind you that A is not appropriate, as it should only be used in diagnostic purposes and then given concomitantly with the vasoactive medication. B, patients with HRS AKI had only a limited recommendation for albumin plus midodrine and octreotide. And additionally, albumin plus norepinephrine was only demonstrated to have significant survival rates at 90 days in transplant-free patients if they were receiving terlipressin, which is why C here is the correct answer. As we think about applying this to our own institution, we think about the new mega policy that was just approved and put into for our use. We did just approve norepinephrine to be administered in the trauma step-down unit in addition to all the ICUs, which was previously. Of note, though, the cost is still fairly significant of terlipressin in comparison to norepinephrine. If we were to apply this to Erlanger, let's take a more specific application by looking at a case. A 58-year-old male with a past medical history of HFrEF, hyperlipidemia, cirrhosis with ascites, and SBP weighing 65 kilograms is admitted. The intensivist wants to initiate terlipressin for 2 milligrams IV per day, along with albumin 40. What recommendation would you make regarding the dosing of terlipressin? Again, the answer is currently highlighted for you, but I want to note that terlipressin given 0.85 milligrams IV Q6 is what is currently recommended in FDA guidelines, which is why A is the correct answer. B, patients received terlipressin, receiving it via continuous IV administration was demonstrated to have increased mortality rates at 90 days. And lastly, the C is an incorrect answer because primarily the average of patients who received albumin in the study examining terlipressin for our US patients in CONFIRM had a median of 40 grams per day over the 20 grams per day of albumin. If we do end up initiating terlipressin, what are the things that we need to monitor? A, SpO2, serum creatinine, ACLF grade, and volume status. As you can see, the answer would be all of the above. This is specifically recommended in the package insert for terlipressin and is based on the trials that we just walked through. Now that we've looked at some case examples, keeping these in mind that these are complicated patients, what might this look like for us? I reached out to pharmacy colleagues within our region and obtained this management protocol that our Vanderbilt uses. Of note, Vanderbilt is a liver transplant center, which may differ how we would apply this to us versus them. However, it does demonstrate and is very much literature-based in making sure that we are first giving albumin challenge, then removing all diuretics, checking if a patient has a CVP less than 4 or greater than 10 and giving them the appropriate therapies, and then initiating norepinephrine, at which we would titrate using their urine output or MAP as defined in one of the studies that we reviewed during this presentation. At their institution, they use a non-titratable norepinephrine drip, which could potentially be initiated here. As we look at future studies and what they might bring to the table as we think about these patients, I would recommend that we look further into continuous versus bolus dosing of terlipressin given outside of the ICU. We noted that patients who received CIV administration of terlipressin had higher rates of volume overload in the previous meta-analysis I reviewed. However, this was done in the setting of the ICU. Additionally, it would be beneficial to look at vasoresponse-dependent HRS-AKI phenotype, meaning all of these trials primarily looked at patients with type 1 HRS, and not only type 1, type 2, and there's a potential third one that is also being evaluated currently. And these patients may respond differently to our vasoactive therapies. So in conclusion, we do have new updated definitions and diagnostic criteria of HRS-AKI, which will have major complications in how we treat these patients. While guidelines continue to update, recommending terlipressin as a first-line therapy, further studies and comparisons to norepinephrine are definitely warranted. As we know, in our hospital, this could potentially lead to use on a floor and not requiring an ICU or all of the intensive monitoring that goes along with that. Additionally, going along that line, it would be beneficial to look at how, again, terlipressin or norepinephrine could be used here at this hospital and make sure that we're accounting for the clinical and economic benefits, as we saw the high cost of terlipressin in comparison to our other therapies. That concludes my presentation. What questions do y'all have? Yes.
So you mentioned the concern for fluid overload in patients with terlipressin. Are there any other adverse events that you would worry about or patients that you might not want to use it in?
The question was discussion of terlipressin and the various adverse events that you may observe with that and what patient populations we would want to potentially avoid giving this medication. Obviously, volume overload was the most significant. However, the confirmed study that was done evaluating terlipressin and led to its approval, the patients received significantly higher doses of albumin, and albumin was not controlled during that study. That was the only study that demonstrated higher respiratory adverse events. So it's important that if we were to use terlipressin, especially in a volume overloaded patient, like a patient with CKD or on dialysis, or if they had heart failure, that is one patient. Those are two patient populations we would for sure want to avoid. The other significant side effects listed were peripheral ischemia. However, the rates were very significantly low. They were 5 to 10%. Additionally, the other largest side effect of terlipressin would be GI events, which again, a lot of patients can have, and that's a common side effect of a lot of medications. So I think those are the two patient populations I would be most concerned about. I can't think of another one off the top of my head that would preclude the use of terlipressin. Yes.
So after doing this presentation and all the work that you put into it, what's your final recommendation in terms of terlipressin use? And if you are for using it in our facility, how would you lay that out in terms of like patient monitoring? Where would they have to be put into?
So the question was basically just assessing how my final recommendation based on all the research that was done. I would not recommend terlipressin for the use at this facility unless we had close ties with a transplant center and knew our patients were going directly from us to transplant, as terlipressin was shown to improve transplant-free survival for up to 90 days. So ensuring that a process of monitoring these patients and following them through these transitions of care is basically the only time I would recommend terlipressin. At this institution, I think that it would be we could move towards the use of norepinephrine for the management of these patients and could potentially do it outside of an ICU setting as long as we were monitoring them as with the parameters that I listed kind of in the presentation, especially as we had our first, I don't know, not breach, but where we're moving towards norepinephrine being given on a step-down unit, such as trauma, and still making sure that it's given to our patients in a safe and effective manner. Yes.
Economic difference, like any cost between doing continuous infusion versus bolus? And do you think that there's wiggle room to dose it outside of its FDA approved route?
So the question was evaluating economic differences between giving terlipressin continuously versus via bolus, and if there was wiggle room to use it outside of the FDA approved route. I would recommend using terlipressin via bolus. I don't think I have one of my slides that demonstrates the cost differences. And so the way that it is currently priced, it is based on the FDA approved dosing, giving it via bolus. So that is what the cost here was projected from. And it was if it was used for a 14-day cost. So you would probably use more vials if you were giving it via continuous infusion. And I would imagine that that would significantly impact the patient and inpatient costs.
Do you think that the increased rates of respiratory failure that led to its box warning have anything to do with the difference in bolus versus continuous dosing? Based on what you read?
I think that there was more data demonstrating adverse respiratory events in patients receiving continuous infusion terlipressin compared to bolus dosing. Okay. And then I have, sorry, it's at the very end. I have all of the,
you do have the code.
I do.
Okay.
Sorry, I cannot get to the, there.
Okay, here it is.
Thank y'all for your time.
Next slide, Noel.
Why is this not?
Yes, sir.
Back course.